We're going to move on for the sake of time to our last session and talk about, we think of precision medicine and non-small cell lung cancer, and of course that story was first told by the EGFR and ALK chapters, but we now have other mutations that are druggable, that we routinely identify in comprehensive genomic profiling that has made a meaningful impact on our patients. So we're going to start with BRAF and specifically BRAF-V600E. David, you want to talk about the importance of identifying BRAF and the targeted therapies that are used for this molecular cohort?
Sure. BRAF, it's quite a rare alteration. It's around 2% in non-small cell lung cancer. The most important alteration is the BRAF-V600E. It's among, I would say, 70 or 80% of the BRAF alteration. And what is particularly important in the BRAF, in comparison to the HALK population, to the EGFR population, you cannot select this population to be screened according to the smoking status, because you have only 1/3 never smoker, but 2/3 of former occurrence smoker. So that means you need to screen all the patients, whatever the smoking status, which is quite different from the EGFR and the HALK population. It's mainly adenocarcinoma, so that means you need to screen all the adenocarcinoma to capture this population with a BRAF mutation. And after in this population, what to do? In the first time, as it was done in melanoma, we used to treat with a BRAF inhibitor, which was dabrafenib or vemurafenib. It works, but response rate is between 30 to 40%, and median PFS around 5 months. So I would say it's not the magnitude we might expect. As for the EGFR, for the HALK, you might expect 60% response rate, median PFS around 10 months. So in the second part, we know that most of the tumor cells, they might escape with a HERC or MEK activation when you block BRAF. And as in melanoma, again, we done a trial with subcohort association, a BRAF inhibitor and a MEK inhibitor, which is dabrafenib and trametinib. Two different cohorts. One cohort of patients that have received at least prior in first line, at least a platinum-based chemotherapy, and a second cohort upfront in first line with dabrafenib and trametinib. And when you block BRAF and MEK, in this case, you double the response rate, it's 63% response rate, and you also double the median PFS, it's around 11. So clearly, nowadays, this is a standard in all the guidelines, it's mainly approved in all the countries. And so this is something we need to screen. If you don't screen, you will never find this population. And if you find this population, so you might treat either in first line or second line, you will have and observe the same magnitude of benefit with dabrafenib and trametinib. And also during this meeting, we have seen again a cohort of patients, a French cohort, that it's access vemurafenib, that receive vemurafenib in monotherapy. It's more than 100 patients treated only with vemurafenib in monotherapy. And again, it's confirmed if you block only with a monotherapy, you don't optimize the magnitude of benefit. Response rate is around 40%, and median PFS is around 5 months. So it's not enough. You really need to have this combination to have the best benefit in this subpopulation. And the last thing, because it's also an important question, we target the patient with a BRAF-V600E mutation. What to do with the patient with a non-V600E mutation? It was looked also in the French trial with vemurafenib. And if you block this population with vemurafenib, the response rate is close to 0%, and the magnitude of PFS is between 1 or 2 months. So that means until now, you should block only the BRAF-V600 mutated patient. The non-V600E mutated population, we don't know what to do, and perhaps it might be an immune treatment, particularly if they are smoker.
And not all BRAF are the same.
Exactly. Same as for the EGFR.
Yeah.
You have a specific mutation of sensitivity, you have the intermediate mutation, you have the resistant mutation. We have exactly the same. We have to look if it's exon 15 BRAF-V600E mutation, if it's exon 11, probably this patient should be treated with a different combination, chemotherapy, immune treatment, or other targeted therapy.
So just briefly, global perspective, routinely interrogating BRAF in all your patients and then using it frontline if discovered, or mostly after chemotherapy?
Routinely assessing for these drivers in patients with advanced disease, of course. These drivers frontline as soon as we can with an NGS dedicated panel. Of importance, the smoking status helps enriching in our thoughts for the probability that we think about. But I test every non-squamous patient, when I'm not confidently facing a squamous cell carcinoma advanced disease, and I have no reason to think I'm doing a mistake. I will just test all the non-squamous patients for all these alterations.
So in the UK, dabrafenib, trametinib is not commissioned by the NHS, and as the genotyping at the moment follows the drug approval, the UK patients don't have access to this, and they're being genotyped in research programs and having BRAF inhibitors in the context of research setting.
And just quickly, David, toxicity signals with these drugs, pyrexia, are there any others to be mindful of when giving the dual BRAF and MEK inhibition?
You have this type of toxicity quite unusual with this type of compound we don't used to have with an EGFR TKI or HAL TKI with the pyrexia. It's mainly related to the dabrafenib, but it's quite easy to manage. If you need, you can decrease the dose level. It's quite easy, and generally, it's not an issue to continue the treatment. So in my experience, I've never had to completely stop the treatment due to the pyrexia. So you can give anti-inflammatory, some corticosteroid, decrease the dose level if you need, and generally it's completely resolved. So it's not an issue. After, for the trametinib, you need to, there is some patient that might develop some pulmonary toxicity, but it's between 1 to 2%, so it's quite a rare toxicity. And in this case, you can continue the dabrafenib and stop the trametinib. And lastly, you may observe some digestive toxicity, nausea, vomiting, but it's mainly grade 1 toxicity. So that's quite comfortable.
Well managed.
Yes, and lastly, the cutaneous toxicity. Paradoxally, you have lower potentially proportion of cutaneous toxicity with a combination in comparison to the monotherapy. Okay. So that's why the tolerability is quite fine.
Okay.